Okay, so good morning everyone. Today we continue with Dr. Achra about the third part of her presentation on the breast MRI. We will continue from where we left last week, and the next week will be the last part, I think. Okay, good. So,
Good morning, everyone. Today we are going to continue our third part of breast MRI seminar, starting from where we stopped last week. I would like to just remind you about the fibroglandular tissue and the fatty tissue compartment of the breast that is classified according to the Wolfe classification or the Tabar classification or the ACR classification, which is regarded as a modified Wolfe classification, and dividing it into the 1, 2, 3, 4. 1 is almost always is fatty tissue, and 2 is scattered fibroglandular tissue, and the third one it is moderate, and the fourth one is extremely fibroglandular tissue. We talked also about the background parenchymal enhancement. What is the background parenchymal enhancement, and where you have to look for the background parenchymal enhancement in the acquisition, in a post-contrast acquisition, and in post-contrast acquisition. You have to put in your mind that the background parenchymal enhancement is not the same the fibroglandular tissue. You may have a dense fibroglandular tissue breast, but you have a minimal background parenchymal enhancement. Put that in your mind. And also the background parenchymal enhancement is dividing into the what? Into the minimal and mild, moderate, and marked. The minimal one, in which less than 25% of the fibroglandular tissue enhanced post-contrast, and the mild one, 25 to 50% of the fibroglandular tissue enhanced post-contrast, and the moderate, 50 to 75% of the fibroglandular tissue enhanced post-contrast, and the marked one, more than 75% is enhanced. Before talking about the abnormality and the shape of the abnormality and the enhancement, we have to put in our mind that the improper positions of the breast in the recess of the breast coils is very, very important, making for you a big issue about the finding. For example, that one's on the right side is the improper placement of the right breast. You see, it just looks like a non-mass enhancing lesion. It just looks like a non-mass enhancing lesion, while it's only improper placement of the right breast. And the second one, because it is a big breast, you see that there is a compressions of the tip of the breast. So put in your mind, you have to put the breast properly. And the third one on the right side, you see it because it is small in size, because of the motions, you see that there's inadequate support. Motion artifact appear here, like you may regard this ones as the for example, the right breast is smaller than the left breast, but actually it's not like that. It's only the motion artifact. So that's why you have to put in your mind that the proper positions of the breast in the recess of the breast coils is very important. And the fourth ones on the left side, you see it, these two shadows that appears on both sides of the breast is just due to the improper position. About the sections that have been taken by the breast MRI is the axial section and also the sagittal section. Why this is important? Important just like the mammogram. For example, the axial sections is corresponding to the CC projections of the mammogram, while the sagittal section is corresponding to the MLO sections of the mammogram. Here, the first one is T1 weighted image. You see that there is a fibroglandular, you can see the fibroglandular tissue and also the fatty tissue. But in the next, in the image that's below it, you see that this is T1 post contrast. If you are looking to the image, you can't be able to find out the abnormal enhancement because all of them are overlapping on each other. So that's why the subtractions in the breast MRI is very important, in which the T1 pre-contrast is subtracted from the post-contrast image. Put in mind that the fat suppression on the right side, you see it here, there will be no signal from the fat tissue in the breast. And this acquisitions not depending on the movement or the motion of the breast in the recess of the breast coil. While in the second type, in the second image, which is on the left side, is the subtraction. The subtraction is very sensitive for the motion, because subtraction, it is the collection of a multiple image taken in a different time post-contrast administration. So any movement in this series of the image will making abnormal or wrong diagnosis or mismatching in between the image. You may have a lesion, but you can't see it in a subtracted image. I just like to give you these important things before talking about the abnormal enhancement and the lexicons of the breast MRI, just like the mammogram and the ultrasound lexicon.
So just regarding the subtraction, the idea is you subtract post-contrast from pre-contrast. So if there is any movement between pre and post-contrast, it will not be subtracted correctly. It will be wrong. So once you start the dynamic imaging, pre and then post-contrast, 5 or 6 times, there should be zero movement. Any movement, you might miss something. Okay?
About the breast MRI, what are the information that we can get from the breast MRI? First of all, the morphology of the lesion, if it's present. And number 2 is the functional property of the lesion. And this is done by the dynamic evaluations of the lesion. According to the MRI lexicon, enhancing lesions are classified into what? If you have an abnormal enhancement, apart from the background parenchymal enhancement, you will have a focus in which less than 5 mm in its diameter, and it is non-space occupying lesion. About the mass, 3-dimensional lesion, you can give more characterization to the lesion. I mean, the shape, the boundary, and also the enhancement, intralesional enhancement. So this is a mass, and the other one is a non-mass, which is there's an abnormal enhancement of an area in the breast. So that's why it's called the non-mass enhancing lesion. Let's talk about the breast MRI reporting findings. It's very important to find out the abnormal enhancement. What's important here is you have to put in your mind that whenever you are doing the MRI for a patient, this patient have been go to a series of the imaging, especially the mammogram and the ultrasound, and they found out a suspicious lesion. That's why they send it for you for the MRI. So the MRI is just to tell them that this lesion, is it malignant or it is benign, which is mostly all of them malignant. So abnormal enhancement, you have to search for the abnormal enhancement. Abnormal enhancement may be focus, may be mass, as I told you, and mass enhancing, and later on we will talk about the kinetic curve assessment. For the focus is the most difficult abnormal enhancement in the breast MRI. Why? Because it's very, very small. You can't even to give a more characterization like a shape and margin. So it's unique to the background parenchymal enhancement, especially if it is multiple and bilaterally. Sometimes you regard the multiple focal enhancement bilaterally as a background parenchymal enhancement. No corresponding findings. Here you may face a problem about the multiple focal enhancement, how you are checking out if this multiple focal enhancement, normal or abnormal, you have to put in your hand the other modality, I mean the ultrasound and the mammogram. You have to put in your hand and check it out if there is a real complication, a real finding in the mammogram or ultrasound. Take this focal enhancement seriously. It's not only focal enhancement and benign. What's important here, if you are so doubt about the focal enhancement, the best things you have to do with it is the follow-up within 1.5 years to check out its size after this period of the time. If it's increased more than 20% of its size, it means that it is malignant. But if it is constant,
1.5 years?
1.5 years, yes. 1.5 years.
2 months, 18 months?
Yes, they said that. I wrote it in.
Can you repeat it?
Not each treatment for 18 months.
Over.
Oh, yes.
Okay.
If you have a focal enhancement and other modality will not give you a clue that this abnormal enhancement may goes with the malignant. So better things and better decision for this time is that follow up this focal enhancement in the next 1.5 years to find out if it's increasing size or not. If it's increasing size more than 20% of its previous size, it means it's going with the malignant. And if it's not constant size, the same, it's go with the benign. If you see here, there is a single focal enhancement in this image. By the MRI, you just find out that this is only focal enhancement. So here better to do the follow-up on the right side. But on the left side, if you see it, there is a multiple focal enhancement, usually taking the lobar pattern distribution, and this is going with the non-mass enhancing lesion. Mostly you can regard it as a non-mass enhancing lesion, or you can regard it as a normal background parenchymal enhancement. What I want to tell you is that you have not to give your decision just only on 2 or 3 acquisition. You have to check it out its kinetic curve. You have to check it out the other acquisitions of this lesion. Totally, you have to give your impressions about the lesion. About the mass. Mass is occupying structures with a convex outward contour, may or may not displace the surrounding normal breast tissue. Here, characterization of the mass is very important. First of all, you have to give the impression about the shape, maybe round, maybe oval. The oval one usually sometimes multi-macro lobular, regarding as a round also, or irregular. This irregular shape may have a speculated outline or may have sometime ill-defined outline. Characterization of the mass by the margin. Well circumscribed, as on the right side image, or not circumscribed, maybe irregular or speculated. You can't decide it in the second image. You can't decide it is speculated. Yes, that's right. There's speculations in some part of it, but you can't say 100% speculated. So that's why it's better to say it's irregular. But the speculated one, the third one, it's speculated, and you can say that confidently without doubt. Characterization of the mass. The third characterization of the mass is the internal enhancement. Maybe homogeneous, as is shown here in this picture, confluent uniform enhancement, or heterogeneous, as you see here in this picture. It's heterogeneous, non-uniform enhancement mean. The rim enhancement. The rim enhancement is very important because sometimes it's just only fat necrosis. For the fat necrosis, you have to check this fat necrosis in the T2 weighted, diffusion weighted, and also in the IDC value, and also the kinetic curve. You have to check it out, all of the acquisitions, in order to decide that this is a fat necrosis. For example, here in this picture, the previous one, if you see, there is a rim enhancement. In the T2 weighted image, as it is shown in the image just below it, you see that there is an increasing signal intensity of the lesion. So this is a good sign. And yes, that one said you put it. T1, maybe T2, because T1 and T2 in the breast is very difficult to be differentiated. You have just to check it on the on the machine's window or by the TR and T. And here the rim enhancement, if you see it here in the computer aided detection, it is an abnormal enhancement, and it is invasive ductal carcinoma. Briefly, the right side show the heterogeneous enhancement of a lesion, the first one and the second one, and on the left side is showing the rim enhancement. Both of them are malignant. For the rim enhancement, as I told you, the second step you have to do it, you have to check it out in the T2 acquisition, as it shows here. In T2 acquisitions, the first one, the above image, if you see it, there is a signal void of the rim enhancing lesion. But while in the bottom, in the image just below it, you see that there is increased signal intensity, and that means mostly maybe fine necrosis or maybe fluid containing lesion, and you have to go more by the also checking the diffusion weighted image and IDC. Characterization of the mass, the internal enhancement is very important to check it out. The non-enhancing lines within a mass usually seen with the fibroadenoma, so this is a good sign. But it is not pathognomonic just for the fibroadenoma. You have to think about that also, because sometimes the triple negative breast cancer that appears just look like a fibroadenoma. You have to take this point also in your mind to check that. Here's for the enhancement, there's a rim enhancement the first, but in the stir showing a bright signal, mostly it is cystic lesion. In T1 weighted, it is low signal. Bright T2 signal, if you see there is a fat fluid level here in this lesion. This is mostly infected lesion, infected cyst. Briefly, what we talked about is that enhancing mass lesion is either benign or it's malignant. If the shape is rounded ovals, more going with the benign, but if it's irregular, it's more going to the with malignant. And about the margin, if it's well circumscribed, mostly going with the benign, but if it's not circumscribed, means irregular, speculated, it's going with the malignant. Internal enhancement, the homogeneous one, and their internal septation mostly going with the benign, while the heterogeneous rim enhancement is mostly going with the malignant. Non-mass enhancement lesion, it's a difficult lesion that you can't see it by the other modality, I mean the mammogram and the ultrasound, so you only see by the breast MRI. Just like a mass, non-mass enhancing lesion has a more characterization. First of all, the shape. The shape may be focal, as it's shown here in this picture. May be linear. It means that taking the area just like a linear in shape, or maybe segmental, as is shown here, taking the area of a lobular pattern with the apex directed to the nipple. Maybe regional, as shown here, or multiple region, or diffuse. how you are differentiating that this diffuse enhancement is a non-mass enhancing distribution and it is not a normal background parenchymal enhancement, because if you compare to the other side you will not see the same enhancement just like the right side. So that's why you have to decide that this is a diffuse non-mass enhancing lesion. Distribution of a non-mass enhancing lesion briefly. This is the focal one. This is the linear one. You see that there's just like a line enhancing lesion. Or this one is a segmental, taking the lobar pattern distribution. Or regional, just for example part of the breast included. Or multiple region, as if it's not diffuse but it is separating regions of the enhancement seen here. Or maybe diffuse, taking whole area of one breast. Just like the mass lesion, the internal enhancement pattern of the non-mass enhancing lesion is important. For example, in this picture showing a homogeneous enhancement of a non-mass enhancing lesion, if you see it, you may say it's heterogeneous, but I will show you the heterogeneous one, how it be. Like here, this is non-homogeneous one. The clumped one, in which there is multiple foci are clumping with each other in one area, this is called the clumped non-mass enhancing lesion. The cluster one, as is shown here, both of them are clustered with each other, so represent a periductal enhancement. Predictive value for the malignancy is 77%. It's too much. Internal enhancement patterns of a non-mass enhancing lesions briefly. It's homogeneous, as it's shown here with the orange frame. It's mostly going with the benign, but the heterogeneous and clumped cluster ring, if you see here in a cluster ring and the clump, the clustered one, you will see that there is an internal abnormal signal intensity in comparison with the surrounding abnormal high intensity tissue. So this is going with the clustering, while the clumped ones is not like a cluster. It's mostly all of them have the same enhancement, but they are clumped with each other. Tissue enhancement pattern. So about the breast tissue, as I told you before, mostly composed of a fibroglandular tissue and fat tissue. We are doing the fat suppressions for the fat tissue, but the fibroglandular tissue, you have to see the enhancement pattern of it. The normal and abnormal tissue in the breast are going to take the enhancement. If you see here this line, the blue one, if you see the curve is a shallow curve, and you can say it's normal without any change. This is the normal. Usually background parenchymal enhancement is at this level, while the others, for example the green one and the yellow and the red ones, all of them are abnormal enhancement, whether they are normal or they are abnormal, but this is abnormal enhancement. You have to put in your mind. As you know, the first one, which is called the constant curve, it's a progressive increasing in the enhancement. Less than 10% may be malignant, okay? While the plateau one is 50 by 50, it means that maybe 50% it's malignant, and the washout, it's highly suspicious, more than 85% it's malignant. And easy to remind it is that the three curve on the up on the
three abnormal curves.
yes, the three abnormal curves, and we have the normal curve, the blue one. Kinetic curve assessment, as I told you before, just to remind you briefly, there's two phases, initial phase and the delayed phase. The initial phase including the taking contrast, the curve of taking contrast to reach into the peak. In the peak, after that, series of the image that have been taken after 90 seconds is called the delayed phase, and delayed phase will show you is it persistent or it's plateau or it's washout lesion. I told you that and I talked about it in detail in the first part of our seminar. And the delayed enhancement phase after 2 minutes, or when the curve changes, use it to describe the curve shape. It's very important to depend on it whether this lesion is going with mostly malignant or benign lesion. And these are series of the image. Without using the curve, you can scroll over these series of the image to evaluate the dynamic property of the lesion. The first one is the persistent kinetic curve. As you see it here, is the same, is increasing in the intensity with the time. The second one is the plateau. If you see that there is a constant enhancement of the lesion, not changing, while the third one, which is a washout kinetic energy, if you see in the free image, there is a decrease in the signal intensity with the time. About the findings, we talked about the focus mass, the mass enhancing kinetic curve assessment. Associated feature, what does that mean? Associated feature including the nipple retraction, skin retraction, nipple invasion, skin thickening, axillary lymphadenopathy, pectoralis muscle invasion, and the chest wall invasion. This lexicon, MRI breast lexicon, is very important to put in your mind in order to not to miss any part of the breast tissue. So associated features here, as it's shown here in this picture, nipple retraction with the skin retraction. You see it here, and also the other one. There's a nipple retractions with the skin retraction. And this one is not only retraction, it's invasion of the skin and also the nipple. But here it's just only retraction, while the other ones is the invasion. Here there is a skin thickening, as is shown here in this picture, compared to the right breast, which is quite normal. Axillary lymphadenopathy, here shown an axillary lymphadenopathy, and also you have to comment on it in the MRI report. And pectoralis major muscle here, as it's shown, which is very difficult to see it by the other modality, MRI or mammogram or ultrasound. Other finding briefly: skin thickening, as it's shown here on the right side, with a nipple retraction. There's a pathological lymph node here, as it's shown. And here's a post-operative seroma with a fat necrosis. And there's also a nipple retraction. And this one, there's skin thickening with pectoralis muscle invasion. As I told you before, that T2 weighted image is very important to look for the prepectoralis edema. I think Dr. Omar asked me. Prepectoralis edema appears just to look like this. Okay, if you have such an image, such a finding with a low intensity lesion, you have to think it's malignant. A big person, malignant, most going with the malignancy. Non-enhancing finding. Sometimes there's a lesion, but they are not enhancing in post-contrast. Let's know what are these. Ductal pre-contrast high signal on T1, benign and due to the ductectasia. You see it in the ultrasound and mammogram, but in MRI you can't see the enhancement, and this is called non-enhancing finding. Or like here, T1 pre-contrast. When you are doing the subtraction, there is no enhancement. And also, this one, there is no enhancement. About the cyst, well circumscribed, fluid, imperceptible. You will see it in a pre-contrast administration. There is a lesion, but post-contrast you can't see enhancement. So this is called non-enhancing finding, as it's shown here in this picture. Not taking the enhancement in subtraction image. And also the hematoma or seroma, simple or more complicated, may be bright on T1, secondary to the blood product, or may have a fat fluid levels, as I show you a picture, or thin peripheral enhancement here. If you see in a subtracted image, there is no enhancement. Skin thickening following the surgery or radiotherapy. Here in this picture, there is a skin thickening, and sometimes this skin thickening not taking the contrast in subtracted image. So non-enhancing lesion and enhancing lesion, briefly we are talking about it. All the malignant lesion, they are taking the contrast enhancement. The only one which is just 1% of the malignant lesion that are not taking the enhancement, contrast enhancement, is the ductal carcinoma in situ. That is it. But you have to check it out that this is a ductal carcinoma, and this is by mammogram, putting mammogram on your hand, and the abnormality check it out by the other modality to be confirming the diagnosis that you put on the breast MRI. Fat containing lesion. What are the lesions that containing the fat? And you may be happy when you find it out on the acquisitions of the breast MRI. Lymph node, normal or abnormal, both of them may contain, they contain the fat necrosis, and hematoma, or post-operative seroma with the fat necrosis. Breast MRI reporting impression is very important. Overall summary impression to give it to the physician. Give assessment category BI-RADS, just like other modality. If additional imaging recommended, for example, targeted ultrasound, provide suggestion for next course of the action, or BI-RADS, especially for the BI-RADS 4 lesion, if possible, mass is found on the targeted ultrasound, recommended guided biopsy. Also recommended MRI guided biopsy of the finding. Breast MRI reporting impression, based on the BI-RADS category for the mammography, is the same. Just the category of BI-RADS 4 has not divided into the BI-RADS 4A and B, only BI-RADS 4 in the breast MRI. Category 1 is negative, 2 benign, mostly for the cyst and an enhancing scar and implant. Conclusion is that there is no MR evidence of malignancy. Category 3, probably they are benign, less or equal to 2% likelihood of the malignancy. Limited data for guidance at present, and continue to evolve as data become available. Category 4, suspicious, low to moderate probability of a benign malignant, more than 2%, but less than 95% likelihood of the malignancy. About the category 5, is highly suggestive of the malignancy, almost certainly malignant, and even if histopathology negative, surgical resection should be recommended. Even the histopathology is negative by MRI. If it is category 5, you have to resect it by the the lesion, because the likelihood of the malignancy in a category 5 is more and equal to the 95%. Known biopsy is proven to be malignant. Note if the suspicious lesions is found in addition to a known primary, which will after management read as a category 4 or 5 as appropriate. It means that if you have a lesion in the right breast and it is proven that this is a malignant, and taking the category 6 BI-RADS, and then you will find after resection, and you find out that there is another lesion recurrence. You have to give to this lesion also category, any category from 1 to 6. Here is it. It's briefly talking about the BI-RADS classification of a lesion, and also this one is normal, benign, probably benign, suspicious, thought malignant, or no malignancy. BI-RADS and supplemental descriptors for the evaluations of the lesions at the breast MRI, sequences and description. For example, in T1 weighted in native one, breast composition is very important to say its fibroglandular classification, how would be. The TM almost entirely fat, as I told you. And then in a T1 post-contrast, approximately 90 seconds, subtracted one. Background signal is very important to talk about it. Background parenchymal enhancement, and give it classification to it. And also any abnormal enhancement lesion, if you see it, like a focus, mass, non-mass enhancing. Later on, you have to talk about the T1 dynamic source of the image that have been taken after the first image in 60 to 90 seconds after contrast administration. Signal intensity time curve, in which you have to look to the curve and give it the impressions about is it persistent, or it is plateau, or it is washout, something like that. And also in the initial phase you have to, so it is slowly increasing in the intensity, or it's medium increasing in intensity, or it's a very fast increasing in intensity, which is mostly going with the malignancy. Ultra fast, as I told you before in detail, is the inflow curve of the lesion, time to the enhancement, and maximum slope. Also early taking of the enhancement, or intermediate or late one. I talked about this in detail in the first part of our seminar. T2 lesion is very important. Whenever you find out any lesion, signal intensity, high signal intensity, you have to find out, you have to look to the T2 acquisition to see if there is any edema, or is there any fluid content of the lesion. In diffusion weighted image, this is for the evaluation of level of the diffusion, whether it's restricted or it's not restricted, and giving the value, B value, which is less than 1.2, mostly going with the malignancy, and more than it going with the benign lesion. Thank you. The third part of our seminar is finished today.
Very nice. So, any questions, comments?